Greetings. Greetings, and welcome to the first presentation of the 6th season of our CF Discovery Series, CFRI Live. I am David Suhu, the recently retired Director of Programs and Operations for Cystic Fibrosis Research Incorporated, CFRI. I just couldn't stay away. Actually, I'm filling in for Sue Landgraf, our Executive Director, who is down and out with the respiratory virus. And I am very pleased to be here tonight. Welcome to both our guests in the room and online. Tonight, Julie Matel with Lucile Packard Children's Hospital, Stanford, will discuss gastrointestinal challenges of cystic fibrosis, enzymes, laxatives, and beyond. And I'm sure that I can speak on behalf of our CF community and say that we are looking forward for this interesting and informative presentation. Before getting started, I want to thank Genentech, AbbVie, Cystic Fibrosis Services Pharmacy for generously sponsoring tonight's event. As always, we urge you to work together with your healthcare team. Please note that no information presented tonight is intended for a patient's diagnosis or treatment. We will leave that to your specialists. Tonight's program is being produced by your CFRI Live team, Scott Wakefield, Mary Convento, and yours truly. I encourage everyone to ask questions of Ms. Matel. We are all here to learn. Online viewers, please click on the chat box on your screen and type in your questions. So let's get started. Tonight's topic is of vital importance as GI challenges and are extraordinarily common for those with CF. It is my pleasure to welcome Julie Matel, registered dietitian and certified diabetes educator at Lucile Packard Children's Hospital, Stanford. As the CF Center's clinical dietitian, Ms. Matel works closely with CF patients to manage the many GI issues they face. So please help CFRI welcome Julie Matel.
Thank you so much. It's a pleasure to be here tonight to talk to you about gastrointestinal challenges and cystic fibrosis. So what I'd like to accomplish tonight, hopefully, is to briefly review normal digestion and absorption, review common gastrointestinal problems in cystic fibrosis, including symptoms and management, review the literature on probiotics in CF, because I know that there's been a lot of interest in that area, and then finally provide some recommendations for its use. So this slide shows you the organs that are involved in the process of digestion and absorption. And so when we eat a meal, the food travels down our esophagus and into our stomach, and the stomach sort of acts as a holding reservoir. It has acid present, which mixes with the food. And when the food leaves our stomach, it's called chyme, and it travels into the intestines where most of the digestion and absorption takes place. So the organ pancreas, which sits behind the stomach, does a lot of important work in digestion. It produces enzymes, which then enter the small intestine and break down components of the food we eat, including fats, proteins, and carbohydrates. And so as many of you may know, in cystic fibrosis, this process is definitely affected. So many people have difficulty digesting and absorbing their foods that they eat. And mainly this occurs because the CFTR mutation, which is affected in CF, is expressed all along the intestinal tract. And instead of thick, slippery mucus, a thick, sticky mucus is produced. And this can cause many problems, such as blocking the pancreas so that digestive enzymes can't enter the small bowel, which then further damages the pancreas. Can also cause problems with the motility of food as it moves through the intestinal tract. And then a thick, sticky mucus collects also in the intestines, which can affect or serve as a barrier for absorption. So many of these issues in CF can cause problems with digestion and absorption. So the most common gastrointestinal problems with cystic fibrosis are listed on this slide, and I hope to cover most of them tonight. Gastroesophageal reflux, pancreatic insufficiency, small intestinal bacterial overgrowth, distal intestinal obstructive syndrome, and constipation are all common problems. Pancreatitis is also listed here, but I won't have time to cover that particular disorder tonight. So the majority of people with CF, about 85%, have pancreatic insufficiency and require enzyme. While the genotype that a person has strongly predicts pancreatic functional status, and pancreatic insufficiency is most common in the more severe mutations, which are class 1, class 2, and class 3. And then the CFTR is absent or non-functional in these particular classes, and delta F508 is considered a class 2. So people with the more severe mutations tend to have pancreatic insufficiency. There are a number of studies that we can do to determine whether somebody needs enzymes and if they're pancreatic insufficient. One is the stool elastase, and this has become a more common measure of pancreatic function. It's an indirect measure, and what we do is collect one stool sample and measure elastase and the presence of that in the stool. Elastase is a human and pancreas-specific enzyme, and it reflects the levels of other pancreatic enzymes that the pancreas produces. So elastase values of 200 or greater indicate that a person is pancreatic sufficient and would not need enzymes. If the elastase values are less than 200, then that reflects the need for enzymes or pancreatic insufficiency. There are some limitations to this particular study, however. It's not a particularly sensitive test for indicating early changes in function. So for example, people with more mild pancreatic insufficiency may not show up on this particular study. And it also, the results are influenced by other intestinal diseases, such as celiac disease. And individuals with diarrhea may actually demonstrate false positive levels and have to have this study repeated. So those are just some limitations to this particular test. So once we've done a fecal elastase study, and if we've determined somebody needs to take pancreatic enzymes to help digest their food, they are prescribed, and they're taken with every meal and with every snack. Enzymes are actually a capsule, and within the capsule are these little microspheres, these little beads, if you will. And each of those little beads are coated, enterically coated, so that they are protected from degradation by the stomach acid. So the idea is to get these enzymes into the small intestine where they do the job of digestion and absorption. One issue with people with CF is that their pancreas may not produce enough bicarbonate into the small intestine, leaving their duodenum a little more acidic than it should be. And so a little more acidic than they should be. So then the problem is that enzymes don't get activated where they should in the small bowel, and they may not have optimal absorption because of that. The strengths of the enzymes are expressed in lipase units, and that's the fat digesting enzyme. And we usually dose pancreatic enzymes based on a person's weight and maybe even the fat content of their meal. So if people are eating larger, fattier meals, they typically need more enzymes than if they have smaller, less fatty meals. One thing I just wanted to point out too is that high doses of enzymes may result in fibrosing colonopathy, which is a condition of scarring of the colon. And in the 1990s, when really high dose enzymes were prescribed, there was an increased incidence of this condition, and that was recognized. And so there were enzyme dosing guidelines considered. And so now we follow those guidelines, and we don't see this condition as frequently. So this slide just goes over some factors that influence an individual's response to their enzymes, whether or not their enzymes work well. I talked a little bit about the pH in the intestine and how that affects or delays our activation of enzymes and may affect enzyme function. Also, if people are taking expired or enzymes that have been inappropriately stored, this can also affect their response to their enzymes. Folks that graze all day long, kind of snack throughout the day, may not get as good of an enzyme response. Also, the timing of their enzymes plays a big role. And then finally, poor adherence, which could occur because of the treatment burden, desire to be thin, etc. So how can you help your enzymes do their job? It's recommended to take enzymes right before and or during meals and snacks, and that's just so that the enzyme can mix with the food to do the digestion of breakdown of the carbohydrates, the proteins, and the fat. Pay attention to your expiration dates on your enzymes and discard them when they've reached their expiration date. Make sure you store enzymes in a cool, dry place. So I have an interesting story. I met with a patient in clinic one day, and she was having stomach pains, so gas and bloating. And so we went over her whole enzyme dosing regimen, when she takes her enzymes, is she paying attention to expiration dates? And she was doing everything correctly. But it turns out she was storing her enzymes in the trunk of her car in her backpack while she was at school. And so once she stopped doing that and started bringing her enzymes with her to class, her symptoms improved quite a bit. So that does definitely play a big role. And then finally, making sure to take enzymes with everything except foods that contain simple sugars. So foods that have simple sugars like hard candies, fruit juice, Jell-O, and soda don't require pancreatic enzymes. We have enzymes that sit in our intestines that do the job to break down these simple sugars. So you don't need to take your enzymes with these foods. However, I hope that most of the people that I work with are not consuming too many of these foods for snacks because they tend to be lower in calories. Really want that fat with every meal and every snack that you have in order to improve weight. Just some tips for parents with younger children. Again, each of those little enzyme beads has a coating to protect it from the stomach acid. So you can't let enzymes sit in foods because that breaks down that coating. So it's important to give enzymes in an acidic-based food, such as applesauce, fruit purees, jelly, or ketchup. And one other thing I want to mention about younger kids, especially toddlers, they may go on enzyme strikes. And I wish I had a room full of parents with toddlers, because I bet you more than half of you would raise your hands and say that your toddler is on an enzyme strike. And that tends to happen around 2 years of age. And so usually when that happens, we have to talk about some parenting strategies to help our kids take their enzymes. It's sort of like brushing your teeth. You wouldn't let your kid go to bed without brushing their teeth. Same goes for enzymes. It's that important to take them with every meal and snack. So offering a toddler an option for what they want to take their enzymes with might give them a sense of control and help with their adherence with enzymes. So Johnny, do you want to take your enzymes with applesauce or ketchup? Giving them a couple of options. Next, encouraging younger children and kids to avoid grazing or snacking all day long can be helpful, because there's just so many opportunities for missed enzyme doses when that occurs. Kids do need to consume frequent meals because they have little tummies, and usually that's 3 meals and 2 or 3 snacks a day with planned enzyme administration during those times is really important. We recommend avoiding excessive juice because juice can sort of fill these little tummies and make them not want to eat a meal. Also, juice can contribute to secretory diarrhea, which can sort of be confused with malabsorption. So important to not consume excess juice. And then finally, not forgetting to take enzymes with milk or supplements that are consumed alone, because they contain fat and protein, which require enzymes for digestion. So moving on to how do you know if your enzymes are working well? This slide just sort of gives you an idea of what a healthy versus an unhealthy bowel movement is. And I usually in clinic, I'll ask families and folks to tell me a little bit about their stool output, and it can be an embarrassing subject. And a lot of times I get the response, well, they're normal. And what's normal for me may be different than what's normal for you. So this slide kind of goes over what is considered sort of a normal stool. Normal stools occur within a reasonable frequency, and that can differ with age. For example, infants might have a bowel movement every time they eat, and that's perfectly normal. And this tends to change as we age, with fewer frequency of bowel movements as we get older. And I think it might be normal for an adult to have 3 bowel movements a day, but if you're having more than that, there could be some concern. Also, if stools are large and bulky, take several times to flush the toilet to evacuate the stools, that could be an issue. Or if stools have a stronger odor than the other family members in your house, that can indicate malabsorption. Or if you see oil on the surface of the toilet water or lining the toilet bowl, those can all be signs of poor absorption. So if you experience any of these symptoms, I would encourage you to monitor your stool pattern a little more closely. I've had patients keep stool diaries in writing, and then they can go back and see sort of what their patterns are. And if you see a pattern with any of these unhealthy bowel movements, make sure you call your team for advice about adjusting enzymes, because that might be what helps. And remember, everybody poops, so we talk about it a lot in clinic every time you come in, so try not to be embarrassed because we hear everything. I also wanted to bring up sort of what are some other causes for loose stools, because it's a difficult symptom to distinguish. Lactose intolerance can also cause loose stools, and that's the inability to digest milk sugar or lactose. So what happens is the lactose that's not digested ends up in the large intestine, where bacteria work on it and ferment this lactose and produce gas. And so you would end up with more gas and bloating, some diarrhea, and this usually occurs several hours after consuming milk. And a hydrogen breath test can confirm diagnosis, where we measure these gases in the breath, and the gastroenterologist can perform that study. A bacterial or a viral infection can also cause loose stools. Usually these stools are watery and runny rather than large and bulky. It's sort of a tip when your family or friend base, the circle of family or friends that you have had the same illness. That's a tip-off that what you have may be a bug. And then also the sudden appearance of symptoms, which could be accompanied by fever, stomach pain, and nausea and vomiting, are all signs of a bacterial or a viral infection. And then finally, the use of antibiotics can also cause loose stools. These tend to be watery, and they tend to stop shortly after antibiotics are stopped. Probiotics, which are healthy bacteria, usually in the form of a tablet or a powder or a yogurt, and they contain healthy bacteria, might help with this form of loose stools from antibiotics. And that's mainly because the antibiotics are meant to kill the unhealthy bacteria in your body, and they also kill the unhealthy bacteria in your gut. But in doing so, can also kill some of the healthy bacteria. And so that's where these symptoms come from. Moving right along, I want to talk about the next complication, GI complication, which is gastroesophageal reflux. And this occurs when stomach acid or stomach contents flow back into your food pipe or your esophagus. And it does tend to occur more often in people with CF, and the range is between 35 and 81% of an incidence in CF. And it's likely caused by an inappropriate relaxation of the bundle of muscles that sits at the base of your esophagus before entering the stomach. And what causes this inappropriate relaxation could be excessive coughing. We do know that people with CF also have a delay in their stomach emptying time, which can also contribute to this as well. Many infants have GE reflux but can outgrow it, and it can appear at any age. And the negative thing here is that it can be associated with a worsened respiratory outcome in CF. The symptoms appear a little bit different in adults and children. Adults may experience this burning or discomfort in their chest region, whereas infants and children may experience this repeated vomiting or spitting up and frequent burping. And this can result in decreased appetite or feeling full after eating only a small amount, which can be really detrimental for weight gain, which we're really trying to struggle with in CF. And this can be from not wanting to eat because of the symptoms or losing food and nutrients because of vomiting. So what do you do if you or your child experiences these symptoms? Make sure you talk to your doctor about treatment options. First-line therapy has been proton pump inhibitor medications. That's very commonly used in people with CF. Although I do want to point out that there are some negative side effects with the use of these products, including osteoporosis, pneumonia, and B12 malabsorption. And these have been mainly shown in adult studies in CF. So it's important to talk to your doctor. And there are some non-pharmacological approaches that might be helpful, and these things are listed on this slide. So eating smaller amounts more often, because when you eat a large meal, that can sort of worsen symptoms. Avoiding spicy foods or carbonated drinks. Unfortunately, the fun stuff, caffeine, alcohol, and even chocolate, actually can have an effect of relaxing those smooth muscles that I talked about that are at the base of your esophagus and can make reflux symptoms worse. So if you're having these symptoms, you might want to try laying off the caffeine, alcohol, and chocolate. Also, doing airway clearance before eating may be helpful. And then this next suggestion I think is really important, and that is avoid lying down after eating. Allow about 3 hours between your last meal of the day and bedtime. That can really help with reflux symptoms. And then finally, sleeping with your head of bed raised 6 to 8 inches can also be helpful. Next, I'd like to talk a little bit about constipation. This is the lack of regular stools or bowel movements, can be caused by abnormal stools or reduced movement of the muscles in the walls in the intestines. And again, this is common with CF. The transit time through the intestine is slowed down in CF. And even though the incidence does not differ from the general population, people that are with CF that are pancreatic insufficient tend to have constipation more often, about 1.5 times more often than somebody that's pancreatic sufficient with CF. Although both folks can develop constipation because of this dehydrated bowel that occurs in cystic fibrosis. And then interestingly enough, there has really been no correlation seen between the dose of enzyme and self-reported constipation in people with pancreatic insufficiency. So what are the signs and symptoms of constipation? And this is important to keep in mind, is that we all have sort of a usual bowel pattern, whether we go every day, twice a day, or every other day. And so constipation is when you have a decreased amount of stool compared to your own stool pattern in the past. Usually these are harder stools. However, people can still have liquidy stools that look like diarrhea, even though they're constipated, because the liquid stools can sort of move around the constipated region. And this is usually accompanied by stomach pain or cramps, this feeling of fullness, and not wanting to eat because of a distended or bloated belly. And this can really be a barrier in terms of getting enough nutrition and enough calories in when, especially kids, present with constipation because they just are full and they don't want to eat. So if you think your child or you have this issue with constipation, it's important to talk to your doctor. Oftentimes people with CF are recommended to take laxatives or stool softeners, and these are medications that help soften the stool and move it through the intestines. And one particular medication, which I'm not trying to advocate brand names for, but Miralax, I just wanted to point out, sort of does the job that CF has a problem with, and that is it helps to bring water into the bowel, which hydrates the bowel and moves things around. So it can be very, very helpful. And then some other dietary considerations. Make sure to drink enough fluid, consume a high fiber diet. You can use fiber supplements such as psyllium, which is Metamucil is an example, and get plenty of exercise. And this slide just goes over some of the high fiber foods. I mean, did you know raspberries, a cup of raspberries has 8 grams of fiber. It's quite a bit. That's kind of one of those containers that you get at the store. Also, whole grains like popcorn, quinoa, and brown rice all contain a significant amount of fiber. The peas and legume group, so kidney beans, green peas, black beans, this is a huge amount of fiber, between 14 and 16 in 1 cup. I mentioned berries. The berries tend to be the highest of the fruits, for sure. And then finally, nuts and seeds. So a serving of almonds, flax seeds, or walnuts have quite a bit of fiber. And a 1 ounce serving is a tiny little handful of these things, so it doesn't take much to get the fiber. And I just wanted to point out that make sure that if you're adding fiber to your diet, you get plenty of fiber. Again, because people with CF, with this dehydrated GI tract, if you add a bunch of fiber, you're going to end up with larger feces load and nothing to move it through with. So you really have to have the water with it to help move things through. Another thing I wanted to point out too is that little tummies can only handle so much fiber. So adding a lot of fiber to a child or a toddler's diet can be a little bit of a problem because then they fill up and then they won't have the appetite to get the calories they need, so you don't want to overdo it with fiber with the youngsters, the really little ones. The next topic is distal intestinal obstructive syndrome, and this is a lot like constipation, although a little bit worse, but it occurs in a different area of the intestines. The distal intestinal obstructive syndrome tends to occur where the small intestine meets the large intestine at the ileocecal crest there, and it tends to move downward, whereas constipation tends to occur in the lower portion of the large intestine and move upward. So it's just a different location. And it occurs in patients of all ages, more often in people that are pancreatic insufficient, and it's, again, a more severe form of constipation. And it usually occurs, again, with this problem of malabsorption or a dehydrated bowel in people with CF. And interestingly enough, people with CF that are ill with a respiratory exacerbation may be more at risk for having DOS occur. And that's because they're less active and they may be dehydrated because of fever and poor fluid intake. So what are the signs and symptoms? Crampy abdominal pain, mainly in the lower right quadrant. Poor appetite, gas, but don't be fooled. You can continue to have some stool output even though you have this syndrome. You can help prevent it by managing malabsorption, taking enzymes as directed, and then taking proper steps to prevent constipation. You might need stool softeners and make sure you're drinking enough fluid, especially when you're active in the heat or when ill. And I've worked with a lot of patients where this occurs after they've gone on a really big bike ride over a weekend, and they've felt that, yeah, dehydration really brought this on. So it's important if you're really active to stay hydrated, for sure. Okay, our next topic is small intestinal bacterial overgrowth. And this is defined as having an excessive amount of bacteria in the small intestine. And it's common in people with CF, present in about 30 to 55%. And predisposing factors include, again, the presence of thick, sticky mucus in the gut, poor gut motility. Again, this sets the stage for more bacterial growth. Use of acid-suppressing agents can contribute to this, and the use of certain chronic antibiotics. And the interesting thing about research lately in cystic fibrosis is that people with CF tend to have a reduced, diverse bacterial population. So although they may have this condition of more bacteria, the bacteria tend to be less diverse in terms of their species, and they tend to have more potentially pathogenic bacteria. So symptoms of this could be abdominal pain, diarrhea, abdominal distension, bloating, and gas. And symptoms often occur from several minutes to hours after a meal. And usually the diagnosis of small intestinal bacterial overgrowth would be made by the gastroenterologist, and they would perform this hydrogen methane breath test. So individuals that might have this are given this test sugar, and the sugar enters the GI tract and is not absorbed, so then the bacteria in the gut act on this sugar and produce gases, produce hydrogen and methane, which we can then measure in the breath. And so increased amounts of these gases might indicate small intestinal bacterial overgrowth. Management of this condition would be a person might be put on some oral antibiotics to kill the pathogenic bacteria, and then given probiotics, which again is the healthy bacteria to replenish the gut. Also given regimens to increase bowel hydration. And then I just wanted to point out that the risk of stopping the pharmacological agents that are associated with this disorder, such as acid-suppressing medications and antibiotics, is often outweighed by their benefits. These are important medications to help preserve lung function, so it's important to talk to your doctor before you discontinue these medications. And the last topic I want to cover is a little bit more on probiotics. So there's been a surge of interest in this topic, not just among the CF community, but in the general population. So more studies have been sort of conducted on the use of probiotics and how important the bacteria in our gut are for our health. It's a very interesting topic. So what is a probiotic? I'm just going to sort of read right from this slide. The term probiotic refers to dietary supplements like tablets, capsules, powders, lozenges, and gums, and foods such as yogurt and other fermented products that contain beneficial or friendly bacteria, and the organisms themselves are also called probiotics. You probably will see some of these bacteria used in probiotics, the species Lactobacillus and Bifidobacterium. And it's kind of interesting because saying that a product contains Lactobacillus is like saying Julia Roberts is coming to my party. There are a lot of Julia Roberts in the world. So which Julia Roberts are you talking about? And that's sort of what we like to think about when we talk about probiotics, because whereas we've got these species, they have various strains that are really important and can have different health effects. So for example, Lactobacillus comes in a lot of varieties. They come in Lactobacillus GG, Lactobacillus acidophilus, and so on. Same with Bifidobacterium and other species of probiotics. So when I was reviewing the literature on probiotics, it was a little overwhelming. There's a whole lot out there. And probiotics have been studied in the general population for diseases such as diarrhea, inflammatory bowel disease, constipation, and immunity in general. And I have to say that I really think we only know the tip of the iceberg when it comes to using these products. There's just so much more to learn. And I was able to sort of glean out a few of the studies that have been done specifically in CF. And I want to point to that really only a few strains of bacteria have been studied in CF, mainly Lactobacillus GG and Lactobacillus reuteri. Those are the two most common studied in CF. And they've been found to help to reduce pulmonary exacerbations, to reduce intestinal inflammation, and improve gastrointestinal health. But I have to say these studies are small. They tend to be pilot studies, so there's not a whole lot of information out there in CF. If you do want to use probiotics, I just wanted to try and give you a little bit of guidance. You want to look for products that are manufactured by well-known companies, that say the name of the precise probiotic that they contain, say how many organisms are in a single dose, and have the live active cultures label. This slide is a little bit overwhelming, and again, I'm not trying to promote a particular product, but this list, although it's a short list, it's a partial list of products that contain strains that are supported by published human studies. So the indication for their use is on the left. For example, the first indication is for antibiotic-associated diarrhea, and then there's a list of the bacteria that have been studied in human studies for this particular indication. And then the products that they contain that are on the market, Florastor, Culturelle, etc. And then the next main category is constipation, and we have one particular use here, Bifidus regularis, which is found in Activa yogurt. For general GI health, Lactobacillus reuteri, etc., present in BioGaia chewable tablets, and then Dan Active, another product. And then finally, immune support. These bacteria have been studied for their benefits for immune support and are present in products such as infant formulas like Good Start Natural Cultures, Yo Plus Yogurt, and Dan Active. So although I'm not condoning the use of these products, I did want to provide you with something to take home, a nugget of information about some products that have been studied in human studies. But keep in mind that probiotics are not regulated by the FDA, even if they contain the live active culture seal. And various products that you come across over the internet or in the health food stores may not contain enough bacteria for the desired effect. I mean, it's a very specific process here. And they may not contain one of the bacterial strains that have been studied. So different probiotic species and strains confer different health benefits, and that's sort of an important take-home point here. So the bottom line is that probiotics are a promising field of research in the general population as well as for our folks with CF. And a few studies have been conducted in cystic fibrosis. And people with CF may benefit from the use of a few that have been studied, the Lactobacillus GG and Lactobacillus reuteri. And Culturelle is one product that you can get over the counter. It has Lactobacillus GG in it, and it contains about the amount of bacteria that was studied in these research studies. But there really is not enough solid evidence to recommend their widespread use, and we really need larger, longer, and better studies before we can really recommend them. So before I turn this session over for questions, I just wanted to say that you know, I think when you have cystic fibrosis and you require enzymes and you're having gastrointestinal issues, if you're taking your enzymes as directed, if you're getting enough fiber in your diet, if you're drinking enough fluid and getting the exercise, taking the Miralax and the antacid, and you're still struggling with GI problems, really this is the time to see your gastroenterologist, who is a specialist that can help you sort through this very difficult complex of symptoms. So I want to thank you so much for your time tonight, and happy to answer any questions.
Questions from the audience?
There's one back there.
Okay. Okay.
Hi, Julie. We actually have quite a number of questions that came in from our online community. Our online community, by the way, has been growing through this CF Discovery series. The first question I have is, you mentioned about the hot car, but I heard that even keeping your enzymes in your pocket can ruin their effectiveness. Is this true?
Yes, that is true. It really has to do with the temperature that the enzymes are exposed to. And you know, off the top of my head, I don't know what the temperature range is. And some of this is common sense, but keeping the enzymes close to your body and in a warm pocket, definitely, I would think, could definitely inactivate the enzymes. And I want to just say, I have an audience member here tonight, Dr. Zach Sellers, who is a gastroenterologist. So I'm hoping he'll help me answer some of these questions that I cannot answer. But thank you for that question.
Another online participant asked, how do you decide which enzyme to use? What is the difference between them?
That's a really good question, and there have been no research studies comparing one enzyme brand to another. All of the enzymes that are on the market now are FDA approved, and that was mandated, I think, in 2004. So it's safe to say that the enzymes that are on the market do work, but you may have a little bit of the nuances in terms of one person doing better on one enzyme brand than another. Usually we start with looking at all of the things that affect the efficacy or the way your enzymes work first, about storage and expiration dates, and when do you take them, and are you taking them with everything you eat and drink, and we start there. And if people are doing everything as directed and their dose is not beyond the maximum dose, then we might try a different enzyme brand.
How often can my child take probiotics? Once or twice a day? Is there a proper dosage?
Usually the manufacturer will state on their labeling the proper dosage. I don't have that information off the top of my head. So whatever product you're using, usually it'll say, for children this age, take this amount. That's as far as I can go to say the dosage.
Also, do you have any ideas to get my child to eat more fruits and vegetables?
That's the topic of the century, right? Yes, I do have some suggestions there. I think as a parent myself, I struggle with that, even though I'm a dietitian. The first thing I would like to say is that you want to just make sure that you're offering fruits and vegetables all the time, that they're always available at every meal and every snack. Kids usually learn by example, so if the better the parents are at modeling this behavior, the better the kids will be. And sometimes it's just a matter of a food jag or a time in their life. For example, I know that my daughter didn't like vegetables from the time she was 2 till the time she was 8, and it was a big struggle, which I refused to embark upon. And you just keep offering the fruits and vegetables, encourage one bite, making them available. And over time, she finally did accept them into her diet, and she's a great vegetable eater. But it really just depends on the kid. But those are some suggestions.
A separate person asked, my child has been on Prozac to treat reflux for many years. Is there any danger of being on this medication indefinitely?
I don't know, Zach, would you like to comment on that? Being on Prozac. I don't know, should we bring him a microphone? Indefinitely, over time.
So I guess first, as just for full disclosure, I'm not actually a certified gastroenterologist. I'm finishing pediatric residency and will be embarking on my gastroenterology training later this year. But as Julie mentioned, that there have been studies in adults looking at what are some of the side effects of long-term proton pump inhibitor use. We don't have any studies really in children that I'm aware of, but the studies in adults have shown that with long-term use there can be some side effects, and Julie mentioned them. There is an increased risk of osteoporosis. Primarily the study showed hip fractures in older individuals. It also showed that you can have decreased vitamin B12 absorption, and then also an increased risk of pneumonias. And I think it's important to note that while we don't have any studies in children about long-term proton pump inhibitor use, and even more so, we don't have these studies in CF individuals, that it's something for us as physicians, and I think for those people taking these medications, to keep in the back of your mind. Again, I wouldn't advocate that you just sort of blindly or just acutely stop these medications, but it can be worthwhile to have a discussion with your healthcare provider to see if you should continue to take these or if it's worth a break from them, and how you should proceed.
Thanks, Zach. Appreciate it.
We actually have some more questions. As you were answering the questions, we have more questions from other online participants. Okay. What do you think about rewarding children for taking their enzymes regularly?
Okay, that's a really good question. I think I would sort of answer that in the same context that we would encourage our kids to do anything that we require of them. So brushing their teeth, or going to bed at a particular time. And I think that there may be times when a reward is indicated, and I would sort of defer to you as parents to determine when that would be. I don't think rewarding a child for taking their enzymes is a negative thing, but it's something that has to be done, however we can accomplish that. And I think when we end up stumbling upon kids that have trouble taking their enzymes, it's just important to consider that they feel sort of this loss of control, that something that's out of their control. And so doing something that you can to give them a little more control is helpful. So it's kind of like the bedtime. There is no negotiating the bedtime, right? Bedtime is bedtime. But if you get your pajamas on and you brush your teeth, maybe I can read you a story right before we go to bed. So that kind of rewarding behavior I think is probably beneficial for enzymes. Or to say, I know you don't want to take your enzymes, but you need to before you eat. Would you like to take your enzymes with jelly, or would you like to take your enzymes with applesauce? Giving them a little control over the situation can be really helpful, and maybe offering a reward if you need to.
Another person asked a question to tag on to that. She says that her grandson loves kefir, a probiotic, and she's wondering could she reward enzymes with kefir?
Sure. Absolutely. Okay. Sounds great. 2 benefits.
Regarding probiotics, this person says, we purchased probiotics available at Whole Foods, but it was very complicated. What would dosage be for teenagers?
I mean, usually, I would say that based on a teenager's weight, I mean, they usually are at a weight that resembles an adult. So I think, but I really don't know the answer to that question. But you could use maybe an adult weight at the low end is what I would suggest. And again, to keep in mind that probiotics over the counter, you have to consider that they contain a variety of strains that may or may not have been studied specifically with CF, and to keep that in mind in terms of their benefits.
And is there any danger of going off and on Prilosec?
Prilosec.
Prilosec, excuse me.
Dr. Sellers, do you know the answer to that question?
So, in general, one thing that can occur if you acutely stop any proton pump inhibitor is that you can actually have more acid secretion that you had before you went on it in sort of an acute setting. And this is because during the time when you're on the medications, essentially your body gets used to not having that sort of acid, and then once you take it away, there's sort of an enhanced response. Now, over time, that will sort of come back and sort of normalize. But in our non-CF population, when we're looking at coming off of these sorts of medications, this is something that we do keep in mind, either just to let the families and parents know that there may be sort of an increase in some of these symptoms that they may experience, and those should go away over time, or to sort of come down slowly off of the medications. Again, just to sort of tag on to what Julia said, is I think that it's not a clear picture about whether everyone should be on proton pump inhibitors or acid suppressing medications for those in CF, or exactly who should be on them. But we know that there are many benefits for those with CF that those without CF can get. So the coughing and the repeated potential insults from reflux put those with CF at risk for having some, what we call like a chemical pneumonitis, in which you can get some of that acid into your lungs, and those can obviously cause damage to your lungs, whereas a healthy person who is not coughing as much may not have that same risk. So I think the question about what we do with our acid suppressing medications is one that's still out there, and I think that by and far acid suppressing medications are used quite commonly and for long periods of time in CF. And again, I'd say if you're thinking that you might want to trial off of them, to talk with your healthcare provider and to see if that's appropriate and what the best way to achieve that is. So.
Thanks.
Regarding kefir, is there merit to some kefir products containing bacteria that is harmful to those with CF?
I really don't have the broad knowledge to be able to answer that question. I just do not know the answer to that. I apologize.
And actually, this will be the last question because several people online asked regarding the chart that you had for the probiotics in your online presentation. Will it be available, or could it be available to the community?
It was published in a journal. I don't know. Do you guys know if we can make that available? Sure. Okay. Yes, it will be online.
Well, thank you, Doctor, for answering these questions.
Great. There was one other question that was asked by the audience, and this is a response from a representative of an expert, I believe, in the field. The storage temperature for enzymes are usually from 77 degrees to 104 degrees Fahrenheit.
Excellent.
Okay. Great. Okay, thank you so much. I really appreciate that. Wow, thank you so much for a fascinating presentation, which is relevant for both those with CF and those that are caregivers. And thank you again very much for sharing your valuable insights and expertise. Well, this is a wonderful, informative evening, and we share tonight. Thank you again for joining us for our Discover series. A special thanks once again to Genentech, to AbbVie, Cystic Fibrosis Services Pharmacy for sponsoring tonight's CF Discover series. And from all of us in CFRI, we're looking forward to seeing you at our next CF Discover series, which will be held on Tuesday, March 10th. And we're going to have John Marks of Stanford, and he'll be talking about alternative medicine at that time. So thank you again, and good night.